A very good day to everyone. I'm Dr. Jeffery Kang, urologist from University Malaya Medical Center. I would like to talk about the topic of urothelial cancer, the diagnostic assessment and staging. These are few learning objectives. One, you need to identify the clinical presentation. As you know, urothelial cancer, there are two parts, the upper tract urothelial cancer as well as the lower tract, or what we routinely call a bladder cancer. Next, you need to outline the diagnostic modalities and also understanding the staging of the UTUC and bladder cancer. A bit on the epidemiology, the other presenter will talk about it as well. The urothelial cancer is the second most common urological malignancy in developed countries. Male predominant 2 to 1 compared to female, and the peak incidence is 70 to 90 years old because of chronic exposure. Most of the time, 90 to 95%, the urothelial cancer presented as bladder cancer, and in 5 to 10% of time, UTUC. The identified risk factors for urothelial cancer, environment risk factors will be smoking and also aristolochic acid, and genetically Lynch syndrome. I know there are quite a few risk factors that we will always ask for patients with urothelial cancer. However, this occupational exposure, cyclophosphamide, chronic inflammation has no proven study or evidence as a risk factors for urothelial cancer. So the risk factors that are evidence for urothelial cancer will be smoking, aristolochic acid, as well as genetically Lynch syndrome. Next, I would like to talk about clinical presentation. Bladder cancer, normally they present as a painless gross hematuria, accompanied with lower urinary tract symptoms, mainly storage symptoms. They have a lot of frequency, urgency. Some, when the tumor is big enough, it might actually cause a bladder outlet obstruction as well. If they present to you with constitutional symptoms, it's probably already quite late stage because there's normally the presentation of meds like wound pain, shortness of breath, jaundice. In physical examination, you have to perform a bimanual examination. If you can palpate the tumor bimanually, it is normally located at once. Bimanual examination either through a rectum or either through the vagina. If you do surgery under anesthesia, you must perform a bimanual examination before and after the surgery, or what we call TURBT. Why? The reason being is because if after TURBT the tumor is still palpable while bimanual examination, it's very likely that this is a locally advanced bladder tumor. However, studies have proven that this bimanual examination you have to interpret with caution because you might overstage in 11% of cases, and 31% of cases is actually under staging. However, it should still be a routine for you to do a bimanual examination under anesthesia before and after TURBT. In the initial assessment, beside your history and physical examination, you want to send a urinalysis, you have to rule out a UTI, you want to know what bug is causing the infection in the patient by urine culture. You can also send a urine cytology. I will talk about urine cytology later, as well as other bloods like full blood count, kidney function, and etc. etc. Definitive diagnostic modalities for bladder cancer is bladder imaging. It has a high specificity. If the imaging is positive for bladder cancer, you can subject the patient for TURBT straight away. As you can see, this is a ultrasound images of the bladder cancer, right? You can pick up something in the bladder, and this is the CT images. You can see there is a growth in the bladder. If the imaging showed positive for bladder cancer, you don't really need to do a flexible cystoscope to confirm the bladder cancer. You can subject the patient for on-table cystoscope and transurethral resection of bladder tumor straight away. On table, after you perform a cystoscope, identify there is a tumor. How do we confirm it's a bladder tumor? We do a transurethral resection of bladder tumor, and in this picture, we use a resectoscope. It's important for us to take the muscle specimen, the bladder muscle specimen separately during the surgery, so that we will know what is the HPE, as well as we can locally stage what T staging the tumor is. Hence the importance of a bladder muscle in the surgery. Is there any other modalities that we can use to detect bladder cancer, even before a bladder imaging or cystoscope? So for weighted urine, the sensitivity is 84% in high grade or grade 3 non-muscle invasive bladder cancer. If it's a low grade, NMIBC is only positive in 16% of patients. So as you can see, the sensitivity is high in high-grade tumor. It can be high in CIS as well, but it can be very low sensitivity of 28%. So weighted urine cytology, sensitivity 84% in high-grade bladder tumor. So use it with caution because you miss it in low grade as well as a CIS. Therefore, weighted urine cytology cannot be used as a diagnostic tool. However, it is useful to be an adjunct to cystoscopy. You still need to have a cystoscopy for confirmation of bladder cancer, especially if there is no evidence of positive imaging. Cytology, if it's positive, the tumor can be anywhere along the urothelium. It can be either bladder cancer or UTUC, you can't know for sure. How about newer technologies like urine biomarkers? Can it be used to diagnose bladder cancer? There are like quite a few in the market right now. BTA, CX bladder, and also bladder EpiCheck. However, because of the varies in terms of sensitivity as well as specificity and the indication to use it, so far all the evidence as well as EAU is not recommending using urine biomarkers for diagnosis or follow-up. Yeah, for diagnosis, you should still perform a bladder imaging, or if bladder imaging is negative, a cystoscope for the patient. Urine biomarkers, they are not recommended. So after you have confirmed the patient to have a bladder cancer, right, or even beforehand, how do you locally stage the bladder cancer? CT is definitely not recommended. However, MRU can be used, and we can actually classify or locally stage the bladder cancer using this VRAT scoring, vesicle imaging, reporting, and data system. It's something like PRAT score, prostates PRAT score for patients with prostate cancer. Yeah, and systematic review has showed the sensitivity of 78% and specificity of 94% in predicting MIBC and locally stage the MIBC. However, always beware in carcinoma in situ or CIS, there's no any imaging that can detect it. So you should not use imaging to diagnose a bladder tumor or locally stage the bladder tumor because you might miss a CIS. If you were to perform an MRI to locally stage the patient, EAU have suggested that you perform an MRI for local staging of bladder cancer before the TURBT, because after TURBT, the inflammation as well as the tissue reaction might alter the information on the local stage of the bladder cancer. If the patient is confirmed to have a bladder cancer, perform a CT staging, thorax, abdomen, and pelvis, to look for any evidence of metastasis as well as to look for any evidence of upper tract uterine cancer. Now we move on to upper tract urothelial cancer. Normally, patients with UTUC, they present to us with painless gross hematuria associated with flank pain because of obstructions to the upper tract. If they present to you with considered symptoms, it carries worse prognosis because it would probably already metastatic at the point of time. Initial assessment is the same. You have to complete your history, your physical examination, you perform a urinalysis, urine culture, and also urine cytology can be performed as well. We talk about urine cytology and UTUC later, and also other bloods that is needed. Diagnostic modalities. CT renal 4-phase is the gold standard to diagnose a upper tract urothelial cancer. Meta-analysis has shown a sensitivity of 92% and specificity of 95%. Hence, if the CT renal 4-phase shows evidence of UTUC, as you can see, normally we see a filling defect in the delayed phase, you can subject the patient for nephroureterectomy straight away or renal sparing surgery if it's a low-risk UTUC. The other presenter will talk about this later. Yeah. If your CT renal 4-phase showed evidence of UTUC, you can subject the patient for surgery straight away, even without a prior URS or bubble touch or biopsy. Yeah, it's a gold standard. You can perform a MRU if the patient has a CKD that caused him or her to be contraindicated for iodinated contrast media. The sensitivity is much lower, but not too bad, 75%. Ureteroscopy, you only perform it only if you have a diagnostic dilemma. So what we do in URS, we visualize the urothelium, bubble touch. Bubble touch is basically just a cytology from upper tract, yeah, and also a biopsy of the suspected lesion. There's always a concern of performing a URS in the patient with a UTUC that it can increase the risk of bladder recurrence, right? Because when you are doing a URS, you do a URS, you do a bubble touch, you do a biopsy. Meta-analysis and systematic review has proven that by performing a URS and UTUC, it can increase the risk of bladder recurrence. Yeah, that means when you perform the surgery for this patient, like URS, the patient will have a risk of bladder urothelial cancer. Because after you have performed URS, you will wait for weeks before the definitive surgery. And this procedure of URS will cause bladder recurrence. However, there is no impact on overall survival according to systematic review from NOAC et al. Next, can you use a urine cytology to detect UTUC? Studies has proven that voided urine has low sensitivity for detecting a UTUC. However, if you perform a URS and upper tract urine bubble touch, you get the urine from renal cavities, urethral lumen, the sensitivity is quite high, 91%. So if you are performing a URS and bubble touch and biopsy because of the diagnostic dilemma, the surgeon should always perform a bubble touch first, followed by RPG, retrograde pyelogram, because this contrast that we use in retrograde pyelogram can actually alter the cytology or cells. And the reason why we perform a retrograde pyelogram is to look for filling defect, which can be achievable from a delayed phase in CT renal 4-phase. How about biomarkers? Can it be used to detect UTUC? Systematic review has shown that the voided urine cytology and urine markers, we can compare the urine biomarkers versus cytology. So urine biomarkers compared to cytology from this voided urine, that means from the bladder, they have comparable sensitivity, 80 to 100%, and there is higher sensitivity in the urine biomarkers, 35 to 86% versus cytology of 11 to 71%. So generally, voided urine, that means the urine from the bladder is not really sensitive to pick up UTUC. Yeah, so the conclusion from EAU is this lack of high quality data. It's not recommended for you to get a voided urine for urine biomarkers for UTUC. How about we take the urine from upper tract during a surgery like URS? As we can see, there is a data here. In a cytology from bubble touch, sensitivity is 42% and specificity is 94%. And you can see expert bladder, 100% sensitivity, but specificity is only 4%. Fish test is not bad, it's quite good, 87% sensitivity and 82% specificity. Bladder epicheck, 64% sensitivity, 79% specificity. So you can see this wide range of sensitivity and specificity of the urine biomarkers from the upper tract. Hence, cytology and also the urine biomarkers is the ancillary tool for us to diagnose a UTUC. Once you have confirmed the patient to have either a bladder cancer or upper tract cancer, you can perform distant staging. You can do a CT and MRI to look for distant metastasis. And for you to detect a nodal metastasis, the sensitivity is actually 48 to 87%. Low specificity. Pelvic lymph node, you categorize it as enlarged if it's more than 8 mm, and abdominal lymph nodes of more than 10 mm is considered enlarged. Hence, in the patient who has a bladder cancer or UTUC, especially locally advanced, we will perform a lymph node dissection because of a poor sensitivity and specificity of a lymph node metastasis. You can perform a FDG PET-CT scan to detect nodal mets. Sensitivity is 82% and specificity is 84%. However, keep in mind this is a retrospective study. More studies have to be performed to compare the sensitivity and specificity of FDG PET-CT versus CT and MRI. Okay, so this is what I got from EAU. The goal for staging of bladder and ureter cancer. You perform a MRI using a Virat scoring system to differentiate T1 from T2 tumor, a non-muscle invasive versus a muscle invasive bladder cancer. To evaluate locally advanced stage or spreads to lymph node, you can perform a CT scan and MRI for abdominal and pelvic lymph nodes or a PET-CT scan. To assess the upper tract and other distant organs, CT and PET scan is good in detecting that. From EAU, it was suggested for us to perform a cystoscope to rule out bladder tumor. As what I have mentioned earlier, if bladder imaging shows there is positive for bladder tumor, you can perform a cystoscope on table, followed by a resectoscope on table for a TURBT. You perform a CT or MRI, and you perform an MRI only if CT is contraindicated for diagnosis and staging of all upper tract urothelial tumor. And you perform a diagnostic URS if the imaging and voided urine cytology are not sufficient for the diagnosis and or risk stratification of patients suspected to have upper tract urothelial cancer. Next will be a TNM staging of bladder cancer. So the most important in a T staging is you have to differentiate T1 versus T2. T2 is muscle invasive and T1 is non-muscle invasive. Yeah, so this one you have to memorize. T3, it involves the perivascular tissue. T4, it involves the other part of the urothelial system, for example, the prostate, the SV, and also the surrounding organs like vagina, uterus, abdominal wall. Yeah. So if the prostate is involved, the stroma is involved, it is considered as T4 as well. For bladder cancer, the end staging N1 for bladder cancer is it mets in a single lymph node in the true pelvis. N2 multiple lymph nodes in the true pelvis, and N3 lymph nodes in the common iliac, and M is distant mets. For UTUC, it's fairly similar like bladder cancer because they are urothelial cancer. You differentiate T1 versus T2. T2, it involves the muscle. T3, it invades beyond the muscle into the fat, peripelvic fat, right? And T4, it actually invades to the surrounding organ or perinephric fat. The lymph node classification is a bit different. N1 for UTUC is mets in a single lymph node 2 cm or less. N2, single lymph node 2 cm or more, or multiple lymph nodes. M, if it's M1, is distant mets. These are my references: EAU, NICE, AJCC, and Campbell. And with that, I will thank you everyone for your kind attention. I will see you guys later in the UCAP. Thank you so much.